So this has been one of the most anticipated videos on my channel, and I decided to record these videos before we actually hit 20,000 subscribers, such that when we reach 20,000 subscribers, and I'm sure by the time you're watching this video, the channel would have already reached 20,000 subscribers, you will be able to appreciate the ECG much better, and by the time you finish this bootcamp, you should be a master at ECG. I posted on my social media that only 10 people understand ECG in Zambia. Of course, it was a joke, but what I'm trying to say is that a lot of people have challenges in mastering the ECG, and a lot of people have challenges in understanding and being able to pick up certain pathologies on the ECG. So I decided to revamp the video because most of you couldn't find the previous videos that I've done, and some of them are quite long, and the concepts are not as clear-cut as I'm going to explain them in these particular series. So grab a piece of paper and let's go. Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. In this particular video, we're going to be looking at ECG, predominantly the basics. Please do not skip this particular video, even though you have learned ECG from somewhere else, even though you have some ideas and you want to revise. These videos tend to build upon each other and the concepts tend to be interdependent. So if you skip one part, you will be confused in the next video because I do not go over all the concepts in the subsequent video because they'll make the videos quite long. So one question that I have seen most people ask, and I think I posted on my socials asking why it is so hard to grasp the ECG, especially for most individuals, because they tend to think of the ECG in many different ways. There are some who look at different aspects of the ECG. They don't have a way of following through a specific pattern to help you pick out certain pathologies. So I have what I call MK's 3 principles theory on how to understand the ECG. If you follow these 3 things, I guarantee you that you won't have any problems in terms of exams. You won't have any problems in terms of picking up pathologies even in real life. So the first and most important thing is to learn the principles. Learn how to systematically read through and interpret the ECG. The second thing is, of course, to understand what you're looking at, understand the pathology. Remember that all the ECG pathologies must make sense, and science is a branch of education that always makes sense. So whatever you're seeing on the ECG must be explained by your clinical history, it must be explained by your physical examination, unless if it's in an exam setting where they've only given you an ECG and you have no idea of the clinical history behind that same ECG. The third and most important thing is, of course, to practice and repeat the concepts that you have learned. These things are very volatile in your memory, and especially the ECG, because you already have that notion that this is a very difficult topic. You will easily forget and it will disappear from your mind if you never practice these concepts. So don't just watch these videos one time and then pack and say I've understood, and they're clear concept videos. What I like to say, no BS lectures, and then you pack the content and you forget about it. You should repeat this each and every single time at regular intervals, and you'll realize that the more you repeat these concepts, the easier it will actually get for you to grasp and for you to understand. Another problem that I've actually identified is people skipping the basics, which is why I wanted to start with this particular video. You either think it's too easy, it's too boring, or you think you understand the concept, not until someone hands you an ECG that looks crazy and you have no idea what you're looking at. So don't skip the basics. Again, don't rush too quickly and miss vital steps. People tend to rush and skip. Some people will even skip this particular video and go and start watching part 2. Meanwhile, there are some very important key concepts that I've actually explained in this particular video that will help you understand other pathologies later on. So like I said, the concepts tend to build upon each other. Then, of course, the major thing is some people lack the interest, or perhaps maybe you have tried so many videos, you have watched so many videos, you have downloaded so many books, they feel overwhelming and you still don't get the ECG. But I guarantee you, I even made a bet on my socials that if you still don't understand the ECG by the end of these videos, I will send each of you a 50 kwacha. That's how confident I am that if you watch these videos in chronological order and you understand everything that I've said in the ECG videos, you should have no problems in looking at specific ECGs. So let's get into the lecture now. So remember, ECG, also abbreviated as EKG in some countries, it just simply stands for electrocardiogram or electrocardiography. It's just simply a graphical representation of this electrical activity of the heart. Remember that inside the body, there are different structures that carry out certain action potentials. They have a resting membrane potentials, and there's some electricity that is generated in the body. Muscles generate this electricity, and remember, we have cardiac muscles, you have smooth muscles, you have heart muscles. So we can actually connect certain electrodes over the surface of the skin to actually detect these changes in voltage that are passing through the heart or that are within the heart. So these changes are what we call the electrocardiogram or electrocardiography, and they're going to be consisting of waves and deflections, and of course they're going to give you a certain view of the heart. I'll explain this view of the heart very shortly when we look at the different leads that the ECG has. So the clinical diagnosis, like I told you, is going to depend on the patient's history and to a lesser extent on the physical examination, because ECGs could sometimes vary, and what we call normal on the ECG has a very wide variation. You may see an ECG that has maybe an isolated pathology in one of the leads, but it could be normal. You may have one that is completely normal. So what we call normal on the ECG has quite a huge variation, and you must link your ECG to your clinical history. You must link your ECG to your physical examination findings. So it can actually help you make a diagnosis or support your diagnosis in some cases, and it's actually also going to be used for crucial management in specific particular patients. For example, a patient having hyperkalemia, you may see characteristic ECG changes that are obviously going to be pointing you to intervene. So with practice, interpreting the ECG is just a matter of you being able to recognize certain patterns, certain characteristic changes. Usually they come together as a bunch. Then a good interpretation of the ECG, you only understand this when you have a good understanding of the basics and you have a good understanding of certain principles that I will discuss in this particular lecture. When do we do an ECG? So we do it to determine the heart rate. We can do it to accurately define the cardiac rhythm, whether it's regular or irregular, whether it's a sinus rhythm or it's not a sinus rhythm or it's an escape rhythm. We do this to make a diagnosis of old and new myocardial infarctions, to identify any intracardiac conduction disturbances such as your bundle branch blocks, your hemivascular blocks, to do this to look at certain arrhythmias, tachyarrhythmias, bradyarrhythmias. Also determine if there's any hypertrophy of the chambers, any right ventricular hypertrophy, any left ventricular hypertrophy. You should be able to pick these things up on the ECG, and they should make sense when you look at the ECG. Also use it to make a diagnosis of ischemic heart disease, pericarditis, myocarditis, electrolyte imbalances, and even pacemaker malfunction. I'll show you at the end of this series the common ECGs that we'll go through as an exercise as the last particular video, and I think you'll understand and you'll enjoy that video the most because you would be able to follow it through each and every one of those examples and use the principles that we have actually learned over the course of this bootcamp. So remember that the heart is a very special organ. If you pull it out of the heart, if you pull it out of the chest and you put it in this right medium, it will continue beating. Why is this so? Because the heart has a property that we call as automaticity. It generates its own action potentials, and these action potentials are going to be flowing through certain channels, through a certain electrical pathways inside the heart to control the activities of the cardiac cycle. So remember that the contraction of any muscle is going to be associated with electrical changes, what we refer to as depolarization, where you're going to have a positive current entering into the cell or a negative current leaving the cell. So in essence, a depolarization is just like a flow of a positive charge towards the cell, or the cell becomes more positive, its interior becomes more positive. So these deflections, or rather these changes in the polarity of these cells, can actually be detected by the electrodes. And remember that this electrical changes, it's not happening just in the heart, it's also happening in other cells, which is why when you're taking an ECG, make sure that your patient is fully relaxed. Because if they keep moving, they may get interference from, if you keep moving, you may get interference from the skeletal muscle, and they may actually interfere with the activity of the cardiac muscle that you're actually trying to do. So make sure that your patient is still as possible and they're relaxed and they're not moving. So over the course of these lectures, you will be seeing these that are highlighted in bold, which I like to call key points to remember. These are the things that you must take away from this particular video. So from an electrical standpoint of view, the heart will be divided into two halves. It will be divided into atria, it will be divided into ventricles. It's unlike the anatomical division where it's divided into four chambers: right atrium, right ventricle, left ventricle. But we just now combine the atria together and we think of it as one whole, because the heart muscles are connected to each other by gap junctions. So the heart is like a syncytium. So if one of these cells actually depolarizes and is stimulated, the current will flow through all the other cells and eventually the atria will contract as a whole. Similar thing is happening in the ventricle. So that's why we look at the heart as predominantly two chambers, the atria and the ventricle. So the impulse is going to be generated by the SA node. This is very important because the SA node is the one that generates the impulse the fastest. So it will generate the impulse at a rate of 60 to 100 beats per minute, and it will control the other tissues of the conduction system of the heart. So these other tissues are under the control of the SA node, such that if the SA node fails to fire, impulses will be generated from elsewhere, and these other tissues would have, quote-unquote, escaped the control of the SA node. So we refer to those as escape rhythms. So your sinoatrial node or your SA node is going to be found in the atrium, and it's going to be responsible for generating this electrical activity at the beginning of each of your cardiac cycles. So like I said, once it depolarizes, it will spread across the muscle fibers. And remember, the heart is a syncytium, meaning your muscles are joined together by gap junctions. And this will cause your atria to contract, and the atria contracts as a whole. Remember that there are some internodal tracts. There are some tracts which this electrical impulse flows from the SA node to the AV node. You have the tract of Wenck-Bach, you have the tract of Thorel, and you have Bachmann's tract. So these are the different tracts. I don't want you to know those tracts by now. We'll talk about them in detail a bit later on when looking at the details of the ECG. But for now, know that there are some internodal tracts that are present. So now, for the impulse to get from the SA node to the AV node, there's going to be a delay. Because remember, the AV node is the intraventricular node, is the only node where this impulse can actually go through if it's entering into the ventricles. So there's a delay, such that now this delay allows the ventricles to fill up with the blood before the ventricles can depolarize and contract. So this electrical activity is going to be passing through from the SA node through the internodal tracts, eventually spreading also over the atrium, then eventually to reach the AV node. There's a delay for this impulse to reach the AV node. This delay allows for filling of blood. So once this AV node has been depolarized, then it's going to spread down what is known as a bundle branch, the common bundle branch, the bundle of His. And remember, this divides into two inside the septum of the heart. It divides into the left bundle branch, and it also divides into the right bundle branch. Under normal circumstances, the left bundle branch depolarizes first, then the impulse is going to spread to the right bundle branch. This is very important because when this impulse is spreading from the left bundle branch to the right bundle branch, you may sometimes see a characteristic deflection on the ECG. So you may see this Q wave on the ECG. Sometimes this Q wave is actually pathological. I will explain this a bit later on. Then the left side of the left bundle branch is going to divide into two divisions. It divides into an anterior division. It also divides into a posterior division. Because remember that the bulk of the muscle on the left side is much, much larger than the bulk of the muscle on the right side. Then these bundle branches are eventually going to break down and divide into smaller branches, which we call Purkinje fibers, which also depolarize the ventricles. So there's a way in which the ventricles depolarize. I think that should have been the last, or if not one of the last slides that I've actually put in this particular lecture to help you understand. So when we talk about, for example, say someone has a sinus rhythm. It means that number one, the impulse should be generated from the SA node. Number two, the impulse must be flowing through the right channels. And number three, the impulse must be flowing through the right channels at the right time. So there should be the normal timings and the normal delays. Then we say that this person has normal heart electrical rhythm and has this electrical activity beginning at the SA node, following the right timings and the right delays through which this impulse is passing through the heart. So here's the SA node in the right atrium. And of course, here you have your internodal tracts, you have your anterior internodal tract, you have your middle, and you have your posterior. Here you also have your Bachmann's bundle. Then here you have your AV node. Then of course you have the bundle, common bundle branch. Then eventually this divides into the left bundle branch, which has a posterior division and an anterior division. Then you have your right bundle branch over there. So that's like the electrical system of the heart. Now, remember that we're connecting these wires over the surface of the body that are giving us certain views of the heart. So there are two terms I want you to not confuse, and I will explain this right here. So there's something that we call a lead, and there's something that we call electrodes. Sometimes when people refer to the lead, they can refer to one of two things. They can either be meaning that the lead is a piece of wire that is actually connected to the patient's body, which in some cases is true. Or some people can refer to the lead as the ECG recording that is giving you this electrical picture of the heart. So some people can refer to the lead as the actual wire that is connected to the patient in the ECG machine, or they can refer to a lead as the electrical picture of the heart. So in this particular bootcamp, or in this series of lectures, when I talk about electrode, I'm simply referring to the wire that is connected to the patient. When I talk about lead, I'm referring now to the view that we're getting, those different graphs that we get on the ECG machine or on the ECG paper. So remember that this electrical signal from the heart is going to be detected by these wires that are placed over the surface of the body. There are 5 electrodes, which are joined together to the ECG recorder, and one electrode is attached to each limb, and then you have some electrodes which are held by suction cups in front of the chest, and they're moved in different positions. So remember, for you to get this good electrical conduction, or this ECG that has good deflections and waves that are actually you can read, you need to have good contact with the body. So it means if the patient has some hair, you can actually shave off that hair. And remember, it's not necessary for you to remember which electrodes are involved in which leads, but it's very important for you to actually, number one, attach the electrodes to the right part of the arm and attach them to the right positions on the body, so that you don't give an ECG that is going to show you pseudopathologies because you have connected the leads in the wrong way. So for example, if it's they have these inscriptions on them: LA meaning left arm, RA meaning right arm, LL meaning left leg, RL meaning right leg. So you should connect those to the specific areas. Then you have V1, V2, V3, V4, V5, V6, which are connected over the chest. I'll explain how you connect them very shortly. So it means that your 12 lead standard ECG will give you 12 angles at which you can view the heart. So we have what we call the hexaxial leads, or you can call these as the limb leads. So they are either standard limb leads, which are lead 1, lead 2, lead 3, and you have the augmented leads, which are AVR, AVL, and AVF. Then you have the precordial leads, which are also can be referred to as the chest leads. These are the ones that we call V1, V2, V3, V4, V5, V6. So each of these are giving you a characteristic view of the heart from a certain point. It's like you have put a camera on one side of the heart and you're looking at the electricity travel through the heart as it's reaching the camera. So if this electricity is moving towards the camera, that lead or that electrode which is there at that particular side is going to show a positive deflection. If the impulse is moving away from this camera, away from this electrode, then the tracing in the lead on the ECG will show a negative deflection. So keep that in mind. So these views will begin with the hexaxial leads or the limb leads. These ones are giving you a vertical plane. It's like as if you're viewing the heart from the sides of the body or from the feet. So you're viewing it in the what I like to say, the coronal plane. You're viewing it in the vertical plane. So the electrodes can either be placed on the right arm, the left arm, the right leg, and the left leg. So this is where you can place them. You can either place them here, the right arm, the left arm, right leg, left leg. That's if they have like the suction cups or those adhesive pads. Then if they have those clip-ons like the ones where I practice at the hospital where I do my practice, you have those clip-ons that can be connected to the right arm at the wrist, and then the left arm as well as the right leg and the left leg. Make sure you put some sort of gel that is going to help with the conduction, and you don't just connect it to the bare skin. So you have two types of hexaxial leads. You have what we call the standard limb leads and the augmented limb leads. So the standard limb leads are lead 1, lead 2, lead 3. Do not skip this part. Please make sure you understand this part, because this will help you now understand why certain pathologies are seen in certain leads. So these are known as bipolar leads. So they're going to consist of two electrodes which have opposite polarity. There's a negative electrode and a positive electrode, and you have one ground electrode which is going to be minimizing the activity from other sources. Because remember that even other tissues in the body produce electrical current, so you want to minimize this interference. So these are generally going to give you 3 views of the heart. I'll explain how they give you these views of the heart. Then you have the augmented limb leads, which are derived from these other leads, but unlike with the standard limb leads, these ones only have one electrode. They have a positive electrode, and your heart, which is found in the center, because remember it's like you're creating a triangle, the heart which is found in the center is going to be your reference point. It's going to be your zero electrical potential point, which is the heart in the center. So these ones are derived from the standard limb leads through certain algorithms and calculations. And because their voltages are very low, often the ECG machine will boost their voltage, and that's why we refer to them as augmented limb leads. So AVF, meaning that the positive electrode is connected to the left foot. AVL, meaning that the positive electrode is connected to the left arm, and AVR, meaning the positive electrode is connected to the right arm. So those are the augmented limb leads. So a key thing to remember, like I said, the lead is, or the electrode is like a camera. If this electrical current is flowing towards where the positive electrode is, it will give you a positive deflection on the ECG. If the impulse is moving away from this lead or away from this electrode, it will give you a negative deflection on the ECG. Very, very key point to remember. Let's begin with lead 1. So in lead 1, or where do we connect the electrode? So we have our negative electrode being connected to the right arm, our positive electrode being connected to the left arm. So it's like your camera here is on the left side here. It's viewing the heart from the left side. This is where the camera is, where the positive electrode is. And remember that the impulse is starting in this position. It's spreading over the atrium. Eventually it will be spreading in that direction. So it's moving towards where this positive electrode is. So you expect the deflection on the ECG in lead 1 to be positive. So all the deflections in lead 1 are going to be positive. So it means if you see negative deflections in lead 1, it's a problem. It's either you have connected your leads or your electrodes in the wrong way, or there's a problem in the heart. So this one here will give you a lateral view of the heart, because remember you're viewing the heart in the vertical plane. So it's like you're viewing the impulses coming from this direction, from the right side going to the left side. So your camera is on the left side. You're viewing the heart on the left side, which is this arrow here that I've shown you over there. So this gives you a left-sided lateral view of the heart. Then lead 2, on the other hand, connects your negative electrode still at the right arm, and your positive electrode is connected to the left leg. So imagine like you're viewing and the camera is at the left leg here. You're viewing the heart from the inferior side on the left side, going towards the right side here. So this is where the camera is. So remember again, the impulse is starting off from this SA node here, depolarizing over the atrium, and then eventually moving in that direction. The vector is going to be moving in that direction. It's almost very close to where lead 2 is. So lead 2 will give you an inferior view of the heart from the left side, viewing it towards the right arm. So it gives you an inferior view of the heart. Remember, lead 1 gives you a lateral view of the heart. Lead 2 will give you an inferior view of the heart. Then moving on to lead 3, here the negative electrode now moves to the left arm and the positive electrode is kept at the left leg. So your camera now will be at the left leg. It's now you're viewing the heart in this direction from the left-sided or the right side of the body going towards the left side here. So as you can see, the impulse again, the electrical activity is supposed to be flowing in this direction. It's almost like perpendicular to what you are seeing in lead 3 here. So you're going to be seeing that this impulse will be viewing the heart from this angle here. So it gives you an inferior view of the heart, meaning lead 2, lead 3 are giving you inferior views of the heart. Lead 1 is giving you a lateral view of the heart. Keep this in mind. Then the augmented limb leads, like I told you, you have one positive electrode which is connected and your heart is your negative reference point. So if you talk about AVR, AVR is viewing the heart from on top here. Remember, if your heart is in the center here, the impulse is being started off from here and moving away from this AVR lead. So it means that AVR on the ECG is the only electrode which is going to record negative waves. Very important for you to remember, because remember that the impulse is starting off in this area, moving in that direction. So lead AVR, all the waves in AVR are going to be upside down, and they'll record the most negative deflections. The leads in the electrodes in lead 2 are the ones that are going to be recording the most positive deflection, because it's like the impulse is moving towards lead 2. So it's like lead 2 and lead AVR are sort of opposite, mirror opposites. It's only that with lead AVR, it has been augmented by your ECG machine. Then AVL is connected to the left arm. So here you're looking again at the heart from the left lateral aspect of the heart. So you're looking at the heart in this particular aspect here. AVF, you have connected it to the left foot, so you're looking at the heart from an inferior surface. So if you sum these things up together, you'll now have predominantly 6 views of the heart where you're looking at it. The lateral aspect, you look at the right atrium, you look at the inferior surface of the heart. Then moving on to the precordial leads, so we're done with the hexaxial leads. Those are the leads that are connected to the body. So the precordial leads, these ones will give you a horizontal view of the heart. So it's like you're viewing the heart from the front. So you're looking from the front going through to the back. The other ones were looking from the sides. This one now is looking from the front going to the back, and also from the left side, because some of these leads will be, or some of these electrodes will be viewing the heart from the left side, like V4, V5, V6. So where do you connect these? V1 is connected in the fourth intercostal space, right of the sternum. This will give you a view of the septum of the heart. So it means that if there is some problems with, for example, the bundle of those divisions of the left and the right bundle branches, if there's some blockage there, you'd expect some pathologies to show up in the V1 and V2, because that's where these views are looking at this electrical activity that is supposed to be there in this septum. Then, so V1 is going to be connected into the fourth intercostal space, right of the sternum. V2 is going to be connected in the fourth intercostal space, left of the sternum. Very easy for you to connect. You simply count. You feel the clavicle, you can palpate the first rib, first intercostal space, second intercostal space, third and fourth intercostal space. That's where you place V1. V2 is placed on the opposite side, fourth intercostal space left of the sternum. So V1 and V2 give you a septal view of the heart. Then you can also think of them as giving you an anterior view of the heart. V3, you can skip it for now. We'll come to V4. So V4, you're going to divide the clavicle in half, and you count up until you reach the fifth intercostal space. So fifth intercostal space, mid-clavicular line, that's where V4 is. V4 gives you an anterior view of the heart. Meaning if this person has certain changes, for example, a myocardial infarction, and you see that there are changes in V4, it means that most likely we can localize the problem in the heart to the anterior aspect. So V3 is connected at half the distance between V2 and V4. So this gives you pretty much the anterior view of the heart as well. V5 is going to be put at the same level as V4, but it's going to be put in the anterior axillary line. V5 gives you a lateral view of the heart. V6 is put at the same level as V5, but it's going to be put mid-axillary line. And remember, when you're connecting the ECG, and if you don't ask your patient to move their hand away, it means that you're not connecting these leads very well. So V1, V2, septum. V3, V4, anterior aspect. V5, V6, lateral aspect. So like I said, it's like your camera now is in front here, looking at the heart from the front going to the back. So V1, V2 looking pretty much at the septum. It also looks a bit at the anterior aspect. V3, V4 looking at the anterior aspect. And you can see most of them are going to be looking predominantly at the left ventricle. V5, V6 looking at the lateral aspect of the heart. So here's a summary of the heart views and the different things that you're going to be looking at. Remember AVR, looking at the right atrium, but we're not so worried about it. Lead 1, lead AVL, lead 5 and V5 and V6 are looking at the lateral aspect of the heart. Lead 2, lead 3 and lead AVF are looking at the inferior view of the heart. So it looks like it's making like an L on your ECG. Then V1, V2 are looking at the septum, V3, V4 are looking at the anterior aspect of the heart. So these are the leads. So if you want to take a screenshot of this, you can pause the video right now, get a screenshot of this. So these leads are going to be now passing electrical activity in the heart. So remember, our lead 1 here is going to be passing electrical activity from the left side here going to the right side. So if you draw a line through the heart, this is where the line is going to go through. This is how the ECG wave is going to look like. Lead 2 is passing electrical activity from the left shoulder there to the the right shoulder to the left leg. So it's going to be passing electrical activity in that particular aspect. So at 60 degrees. So this is where the waves are going to be showing. Lead 3 is coming from the right arm where the negative electrode is to the left leg where the positive electrode is, so it's passing electrical activity. So if you draw lines through the heart, the vector is going in that direction. So that's lead 1, which is this one here, lead 2, which is this one here, lead 3, which is this one here. AVR is looking at the heart from this aspect. The positive electrode is connected there, so it will be looking at the heart in this direction. AVL, the negative electrode is connected, or rather the positive electrode is connected to the left arm, so it's looking at the heart in that direction. AVF, the positive electrode is connected to the left foot, so it's looking at the heart in that direction. So if you draw these lines, you sort of create sort of like a complete circle with the heart right in the center. So as you can see, the impulse will start off in this area here at the atrium, and it will be moving in that direction here. The cardiac vector, the predominant vector, will be moving towards that direction. So it means if this positive impulse is moving towards these leads which are found on the left side of the body here, these left-sided leads are going to be creating positive deflections because it's like the impulse is moving towards the camera, towards this electrode. So lead AVL, lead 1, lead 2, lead AVF are going to be giving you positive current. They're going to be giving you positive deflections. But AVR here, which is on the opposite side, remember AVR, which is on the opposite side, the impulse is moving away from AVR. So it means all the waves in AVR are supposed to be inverted. We can use this diagram here to now determine the cardiac axis, the flow at which this impulse is moving from the SA node to the AV node and down the conduction system, such that if it's moving towards, for example, moving towards lead 3 here, we would see that lead 3, the QRS complex in your lead 3 here will become more positively deflected. For example, if the heart muscle on this side has increased, this impulse will be moving in a different manner as compared to the normal impulse. But I'll explain these things when I look at the cardiac axis much later on. Here's another example. Now here you have AVL, AVR, AVF, lead 1, lead 2, lead 3, and you also have these other V1, V2, V3, V4, V5, V6, just like that. So those are the leads and how they are passing through the heart. So a key thing to remember is that at the bottom of each of your ECGs, you have what is known as the rhythm strip. So this one here, which is continuous, usually we can get lead 2, which is nice to get as a rhythm strip, and even V1. In this case, they got V5. So lead 2 here, this one which is continuous at the bottom, we call this as the rhythm strip, these ones here at the bottom. So this is what a normal ECG looks like. I just want you to absorb this right now. I won't discuss any details on this ECG apart from telling you that that's the rhythm strip, because I want you to take things slowly and build upon the principles quite slowly. So remember, key point to remember is that normal cardiac vector is going to be towards the left lateral side, so it's going to be from the right atrium there moving in that direction. So any lead which is where this vector is moving towards is going to show positive deflection. So meaning lead 2 here will show the most positive deflection. Any lead which is on the opposite side of this impulse, for example lead AVR, will show a negative deflection. So the most positive deflection would be in lead 2, the most negative deflection would be in lead AVR. We can actually use these things and this orientation and these cardiac vectors to determine whether the impulse is moving in the right direction, or it has slightly shifted towards the right side, or it has been shifted towards the left side, what we call as a cardiac axis. We'll talk about this in detail when we look at the different steps of interpreting the ECG. Now, another thing you need to check is the calibration of the ECG, because you can't sometimes tell if the voltages are high on your ECG or the voltages are low on the ECG if your ECG is not calibrated well. Because if your ECG has reduced calibration, quote unquote, it means that your waves will appear pretty much smaller than they actually are. If the calibration is not right, they may be bigger than they actually are. So remember that your ECG tracing paper has small boxes and it will have big boxes. The big boxes are interspaced by bold lines. So as you can see on this particular ECG here, we have these bold lines which are the big boxes. Each big box is going to be consisting of 5 squares width and 5 square height. So it means each small box is going to be about 1 square millimeter. Each big box is going to be about 5 square millimeters. Remember that your ECG moves at a constant speed of 25 milliseconds. So it means that on the y-axis we have voltage. This axis here we have voltage. On the x-axis here we have time. Because your ECG is moving at 25 millimeters per second, each of this small box on the x-axis will represent 0.04 seconds. If it's for you to memorize this, please memorize. Each box that is a small box is representing 0.04 milliseconds. So it means that 5 small boxes which make up one large box, each large box will represent 0.2 seconds. So if I said milliseconds, apologies, seconds. So this should be about 40 milliseconds. This, or rather 4 milliseconds, this should be about 40 milliseconds and 200 milliseconds. Sorry about that. I don't know what's happening to my math. So because you multiply it by 100. So, or 1,000, not 100, 1,000, sorry. You multiply it by 1,000. So this should be 40 milliseconds. This should be 200 milliseconds. So each small box, 0.04 seconds. Each large box, 0.2 seconds. Then the y-axis represents voltage. Again, 1 millimeter going upwards. Each of these small boxes upwards represents 0.1 millivolts. So it means one big box will represent 0.5 millivolts. 2 big boxes, which is going to be 10 small boxes, will represent 1 millivolt on the ECG. That's your standard calibration. Now, how do you know that this ECG has a standard calibration? There is this tower, this small upside down rectangle that you can see here that will help you determine if this is normal ECG calibration. For this rectangle, for you to determine whether it's a normal ECG calibration, this rectangle here must be 1 box wide and it must be 2 boxes tall. So as you can see on this ECG, it's 1 box wide and 2 boxes tall. So it's normal standard ECG calibration. If you look at the inscription here, 10 millimeters is equals to 1 millivolt and your ECG is moving at 25 millimeters per second. So this is standard calibration of the ECG. Now, before we end this particular lecture, I just want to introduce the waves the intervals and the segments on the ECG, such that when we now go into details of looking at how to interpret the ECG, this will make a whole lot more sense to you. So remember that your ECG is going to be consisting of waves, which are either positive or negative deflections, intervals, which consist of lines as well as waves in them, and segments, which are just predominantly lines. There is a part of the ECG that's known as the isoelectric line, where there is no electrical activity. There is neither positive nor negative deflections. The first wave that we see on the ECG is known as the P wave. This is going to be associated with depolarization of the atria and contraction of the atria. The next wave, which is going to be due to activity of the ventricles, the ventricular muscle, because remember that the ventricular muscle is much, much bigger than the atrial muscle. So this one is going to show its specific characteristic deflection, which we call the QRS complex. Then this represents ventricular depolarization. Then the T wave is going to be associated with the return of the ventricles to their normal baseline, so which is known as repolarization. So the T wave represents ventricular repolarization. A key thing to remember is that your intervals are going to have waves in them, your segments do not have waves in them. So the PR interval will have a wave, so it will have the P wave inside. The PR segment doesn't have any wave inside it. QT interval has the QRS complex wave in it and even the T wave in it. The ST segment doesn't have the wave in it. You would ask, why is it that we use the letters P, Q, R, S, T? Why not any other letters? I also don't know. This was selected in the early days and it was actually just chosen at random. So here's what they look like. Your first wave is the P wave. Next wave is the QRS complex. Sometimes you may not see this Q wave. I'll explain why it's there in some times and why it's not there in some instances, but you have the QRS complex. You have your T wave, you have your U wave, and then the P wave again. So this is what it looks like. So I'll begin with the P wave. So this is the first deflection that we see on the ECG. So this deflection here is going to be representing atrial depolarization and atrial contraction. So this is the impulse flowing from the SA node and spreading over the atrium and eventually reaching the AV node. So all your P waves must be smooth, they must be round, and they must be upright, except in lead AVR. AVR is the only lead where the P waves are going to be inverted. Sometimes your P waves can be absent in certain pathologies like atrial fibrillation. Sometimes your P wave may be peaked, for example, in P pulmonale. Sometimes your P waves could be bifid, or you have like two P waves forming like an M, which we call P mitrale. I'll talk about all those a bit later on. So your P waves must be lasting 0.1 seconds or less. The next bit is the PR interval, which is from the beginning of the P wave to the beginning of the QRS complex. So this is the time it takes the impulse to start off from the SA node and for it to eventually reach the AV node. Remember that there's a delay in between, and this delay is important to allow blood to fill into the ventricles. So the PR interval is just going to be from the beginning of the P wave to the beginning of the QRS complex. So it's going to be the time it takes from depolarizing wave to travel through the atria and eventually to reach the ventricle. The normal PR interval is 0.12 to about 0.20. So about 120 to about 200 milliseconds. So if you want to remember the boxes, it's about 3 to 5 small boxes. So a PR interval could sometimes shorten. So it means that the impulse is moving very quickly from the AV node to from the SA node to the AV node. This is a bad thing because if it's moving quickly through the ventricles will not have enough time to fill up with blood. Sometimes there can be a blockage somewhere such that now there's a delay in movement of the impulse from the SA node to the AV node. We call that as a heart block. The next is a PR segment. Remember, segments don't have waves, so it's the end of the P wave to the beginning of the QRS complex. So this PR segment could sometimes be depressed. So depression in the PR segment usually indicates the pericarditis. The next is the QRS complex, which in essence should have actually been called the QRS interval, because remember, interval consists of waves. The QRS complex is a combination of waves. You have the Q wave, you have the R wave, you have the S wave. So this is going to be denoting ventricular depolarization and ventricular contraction. your Q wave is your first negative deflection, so sometimes you may not see it in some of the electrodes and some of the leads. So this here is a Q wave. Your R wave is your first positive deflection, and your S wave is your first negative deflection after the R wave. Normally, your QRS complex must be less than 3 small boxes, so it must be about 1 to 3 small boxes, so less than 3 small boxes. It must have sharp points and sharp angles. So it means it shouldn't be curved, it must be like a straight line. So if it's curved, then there may be a problem. If it's broad, there may be a problem in this particular ECG. So a key thing to remember, and this here is very, very important. Remember that when the heart actually depolarizes, the impulse spreads in many different directions in the heart, but it will have an average. So this average is what we call the average cardiac vector. And this is going to now influence the shape of the QRS complex in certain electrodes, in certain leads. This average direction of depolarization, if it's moving towards a specific electrode, it will cause a predominant positive QRS complex in that electrode. For example, if it's, moving towards lead 2, it means that you're not going to have your Q wave, but you're going to have an R wave, which is much greater than an S wave. I'll show you a picture in the next slide. So it means that this impulse is moving towards that lead. If the impulse is moving away from the lead, you're going to have a predominantly negative QRS complex wave. So it means that your S wave will be deeper than the R wave, or your S wave will be bigger than the R wave. So it means that the depolarization is moving away from that lead. Then when the depolarization is moving at right angles to the lead, then the RS wave is going to be of equal size. This is very important because there's a natural progression as to which the R and the S wave are actually going to be moving from lead V1, V2, V3, V4, V5, V6. In V1, V2, your R waves are a specific characteristic. V3, V4, they're almost equal size. V5, V6, they're different. We'll look at this when we look at the RS wave progression as we go in this particular videos later on. So this is what I was meaning. So as you can see here, the R wave is bigger than the S wave, so it means here the impulse is moving towards this lead, which is recording it like this. If they're the same size, it means that the impulse is at perpendicular, rather this one here. If they're the same size, it means that the impulse is at a perpendicular distance, or rather at 90 degrees to this electrode. If it's moving away from the electrode, the S wave will be much deeper than the R wave. So this one here, the impulse is moving away from the lead. Now, another important thing to remember is that the impulse reaches the ventricles through the AV node, and the septum depolarizes first before the ventricular walls actually depolarize. And keep in mind that the left bundle branch will depolarize first, and it will give off a cardiac impulse which will spread now to the right bundle branch. This cardiac impulse that spreads to the right bundle branch kind of like is in a different direction to the overall vector that is there in the heart. So this will give you now a small deflection that is negative on some of the leads on the ECG, and we call this small deflection as the Q wave. Then eventually you have the R wave and the S wave. So these Q waves have some special significance because they may be pathological in certain cases. And we'll talk about their significance a bit later on. So this is how the ventricles depolarize. So as you can see, you have the SA node that is depolarizing there, and eventually the left side will depolarize and give off this small vector to spread the impulse to the right bundle branch. So the left bundle branch depolarizes, then it will give off impulse to also depolarize the right bundle branch. So this will cause this negative tiny deflection, which is what we call the Q wave. Eventually, your impulse will spread now across each of these bundle branches rather, and it will reach the apex of the heart. So this means that this predominant vector will be moving in that direction. This will cause a positive deflection, which is what we call as the R wave. Then eventually, the impulse will reach the apex and it will climb on these other sides, and it will be depolarizing these other sides, the walls of the ventricle. Once the walls of the ventricle have been depolarized, this will now give you a negative deflection, which is what we call the S wave. Then, of course, eventually the top part here will be depolarized, and further the S wave will be created, and that's how our QRS complex is actually created, because of how the ventricles are actually depolarizing. So you may have different QRS complex patterns that we'll look at in greater details when we look at certain pathologies. If there's only one wave like this, we call this as an R wave. So this is the first positive wave. So this one is an R wave. If there's a big R wave and a small S wave, a small negative S wave, we call this as an RS, capital R and a small S. So this is a big R wave and a small S wave. If the R wave is small and the S wave is big, we use a small letter R for a small R wave and a very big or negative S wave. Here we have a small Q wave, we put it as a small Q. We have a big R wave and a small S wave, so this is how you abbreviate it. This is the annotation. If they are the same size, if both of them are large, your Q wave will be a capital Q, your R wave will be a capital R. If you don't have an R wave and you just have a Q wave, which is deep, and an S wave, which is deep, so if this is a negative QS complex, we abbreviate it like that. If your Q wave is deep and your R wave is small, it's capital Q, small r. Here, the first positive deflection, we call this as an R wave, so this is a small R wave. The next negative deflection is known as the S wave, with a small S wave. But if you have another positive deflection here, we call this as an R prime. So this is an RS R prime wave. We may sometimes see this in pathologies like your bundle branch blocks. I'll talk about them in details later on. So don't worry if you don't understand this for now. It will make a whole lot more sense when we look at other different lectures. Then again here, small Q wave, big R wave, and then here you just have R wave, which appears notched. Here you have an R wave, and then there's another R wave, which is known as an R prime wave. So here there's no negative deflection that you can see because it doesn't reach the baseline. It doesn't pass the baseline. Same thing here, where it passes the baseline in this one here. Here it doesn't pass the baseline. Same thing here, doesn't pass the baseline. Here we have a fragmented QRS complex. So these are just the different morphologies of the QRS complex patterns. Then the next is the ST segment. Remember, segments do not have any waves. This part here, from the end of the S wave to the beginning of the T wave, this should be at the isoelectric line with a variance of about 1 millimeter. This is normal. Your ST segment must be less than 0.2 seconds, and it's just simply the distance between the S wave and the T wave. It will be the time it takes from the end of depolarization of the ventricle to the beginning of repolarization of the ventricle. The T waves, on the other hand, represent ventricular repolarization. The T wave, remember, ventricular repolarization happens in phases. There is the early phase of depolarization, and there's a rapid phase of, or rather, there's the early phase of repolarization, and there's a late phase of repolarization. So your T wave also must be similar. So you'd have, it will be of course rounded, and it will be upright, except in lead AVR. It will have a slow start and a sharp drop. So a slow and a fast drop. So it's usually asymmetrical. If you get symmetrical T waves on your ECG, that's a problem. It means you could be pointing towards ischemia, it could be pointing towards head injury, it could be pointing towards electrical abnormalities. Your next is your Q2 interval, which represents ventricular activity. So from the beginning of the Q wave to the end of the T wave, this should be about 0.33 to about 0.44 milliseconds. This is largely dependent on the heart rate. If your heart rate is very slow, your QT interval is increased. If your heart rate is very fast, your QT interval is reduced. Then you have the U waves. These ones usually have no clinical significance, but you may sometimes see them in patients with hypokalemia. If the heart rate is very slow enough, you may see these U waves. They just simply represent ventricular, or rather repolarization of the Purkinje fibers. That's the U waves. I really hope you enjoyed this video on the basics, and it has shed more light on the leads, the views, and introduced a bit of some pathologies. Stay tuned for the second video. Please, I'm not going to release this video until you comment that I have understood everything here. Please give us the next video, then I'll release the next video on the ECG. I'll be releasing them every day, slowly, so that you guys can be following, because I realize that if I release all of them at once, it makes it very difficult for you people actually to understand the concept. So if you did understand and you did appreciate this video, show some support. Drop a like, drop a comment. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.